introduce Inez Germeys. Contextual psychiatry from macro to micro environment, and we are double happy that you're here because we were waiting. So you're double welcome to you. She's a professor in contextual psychiatry at the University of Leuven in Belgium, and she told me that she's moving house this week from Maastricht to Leuven, so she has a busy time in many aspects. She's involved in research around person-environment interaction regarding psychopathology in general and psychosis in special, I think. And I'm sure we will hear a lot about experience sampling method during your talk, so please.
Good morning, everyone, and my apologies that I was late, but my train was cancelled, so I had to wait for another one. So if we talk about stress, that was one of my stressors this morning. But I'm really glad that I made it here and that I can share a bit with you some of the things that we have been doing over the last more than 20 years, I have to say, on studying people in their normal daily life and how they deal with the things in their normal daily life. So indeed I will talk about moving from the macro environment to the micro environment. And you have been discussing a lot over the last few days on a macro environment, the city, and how that impacts people and their mental health. And I will try to zoom in a little bit more on the really day-to-day interactions that people have and the effect of that context on their mental state. And indeed, I've studied psychopathology in general, but I have a special focus on psychosis, so most of the examples that I will give is on psychosis. I just continue talking until my slides arrive. If you want to study psychopathology in the context of daily life, then you need methodology that can actually capture that. And so what we've been working on for over 20 years now is using the experience sampling method to capture mental states in the normal daily life of people. And so what we do is we used to give people a watch and a booklet, and they would write in their booklet. Nowadays it's easier, everyone has a smartphone, so they get an app on their phone, and we ask them to fill out, oh, here we are, very nice. We ask them to answer questions in the context of their normal daily life on the app. We usually do that 10 times a day during 6 days at random moments. So we really make it sort of snapshot 10 times a day where we capture not only how people feel, but also their symptoms at that moment and the environment. So we ask them, where are you, what are you doing, whom are you with, how do you feel in this environment, did you encounter something stressful? And that allows us to really look at the effects or the interaction between this context effect and the mental states of people. People often ask me, is this feasible? Can people do this? Is this realistic? Or probably the people that can do this are really high functioning people. And that is actually not true. So we have done this with hundreds of people who have experienced psychosis, depression, general population. We now just did a study in 2,000 adolescents in Flanders, and people can do this quite well. The reason is that it's very structured, so you just get a beep and you answer questions. The questions are questions on the moment itself. So it's a question on, right now, I feel anxious, I feel down, I feel lonely, I feel happy, I feel relaxed. Where am I? What am I doing? So it's really about the current moment. And what I want to do today is explain a little bit to you or give you some examples of what you can do with this methodology and how it can help in better understanding how certain complaints and symptoms develop in the context context of normal daily life. So, first of all, I would like to show that it actually can help in assessing symptoms. And what is very interesting to see is that we see that symptoms vary a lot from moment to moment. So this is, for example, data from a lady who, and we looked at paranoia. So we asked them in the moment, right now, do you feel suspicious or do you feel that someone may want to harm you? On a scale from 1 to 7. And you see that there are moments when this lady is quite suspicious, but at the same time also moments when it's not there at all. And of course that sort of variability is really important to capture, and is also interesting, because if we can understand why at this moment someone is very suspicious but not at this moment, we can start to understand a little bit like what are drivers for that feeling in this person that we maybe can target in treatment. This person, for example, you can see is much more variable, overall higher intensity. So capturing variability is usually quite difficult, but with this sort of methodology you can really capture this moment-to-moment variation. Not just for paranoia, also for hallucinations, where you see that for some people, so this is just moments in time, you see quite a lot of variability, not just in auditory hallucinations, but also in visual hallucinations. Of course, this is self-report, so people are reporting on their own experiences. But as we have shown in our data, people can do that quite well. Of course, you cannot ask someone, are you delusional at this moment? Maybe I am delusional at this moment, but I wouldn't know. But you ask things that people do feel, what they can self-report. Are you distressed? Are you preoccupied by your thoughts? Are you so things that do relate to what people can self-report. We're not only looking at positive symptoms, but also negative symptoms. And I want to give you an example of how experience sampling can actually help to understand better what is actually happening. And let's have a closer look at the symptom of anhedonia, a lack of capacity to enjoy, to have an hedonic experience. So we look at positive affect, and we would say positive affect is sort of an expression of hedonic capacity. You enjoy the things you're doing. And what we see, this is healthy volunteers at risk mental state and first episode of psychosis, 3 different groups. And what you see is indeed that people with an at-risk mental state for psychosis in the first episode have a slightly lower intensity of positive affect. So you could say, well, this is a sign of maybe a beginning of anhedonia. People do not really enjoy as much as healthy volunteers would. However, it's of course also really possible that people do not have so much reason to feel positive, and that it's maybe more related to the environment. So what we did was we asked people between 2 moments, like what was the most important thing that happened to you between the previous moment and the current moment. Of course, that are small things. For me, for example, it was my train being delayed. But it can also be something positive. Right now it would be, there's a nice audience listening to my talk, so that would be a positive event for me. And then we can actually see what happens when people experience something positive, and how does that affect their positive affect? Because then we really capture the hedonic capacity. So this is what we then did. We looked at the moments when people do experience positive events, and we investigated how much that affected their positive affect. And this is what you see. So here is controls. So people, when something positive, the more positive something the more positive the event, the more positive affect goes up. But this is equally true for the 2 groups that we investigated, at risk mental state and first episode of psychosis. So when we look at this graph, photograph, there is no anhedonia at that moment. People do enjoy positive events, only they don't have that many positive events to enjoy. Therefore, their average positive affect is lower as a group compared to the healthy volunteers. So, using this zooming in on the microenvironment can learn us more about phenomenology of the things that we talk about, and can us make understand better so what it is to have this sort of experiences. We can also use this to what I would call capture an interactive endophenotype or phenotype. And that is all about this person-environment interaction. So how do people react to the environment, and how does the environment have an influence on them? And so one of the things we're looking at is, for example, stress. As I said, we ask people between the previous moment and the current moment, what's the most important thing that happens, that can be pleasant or unpleasant. So now let's look at what happens when someone experiences something stressful, something unpleasant, and how does that influence people. And so this is a very old paper that I'm now showing, where we already found that when people have an increase in the subjective experience of stress, that not only affects their negative affect, so their negative affect goes up more in people who are vulnerable for psychosis, but it also affects their psychotic experiences. So people tend to become slightly more psychotic when they have more stress. This is not a transition from mild. We're here talking about patients or service users who were not in a current state of psychosis. So it's not that they then get full-blown psychosis, but just slightly more of these experiences occur, and interestingly, not just in patients, but also in their relatives. So the stressful environment has an immediate effect on how you feel and also on these psychotic experiences. So there is a sensitivity for these stressful environments. Now, what we're currently looking at, and this is already published, so I didn't update the slide, this is now published in Schizophrenia Research. So the next thing we did, we was looking at recovery, because it's one thing to be reactive and to have a stronger effect when you have something stressful happening, but then the next question is, how quickly do you recover from that? And the nice thing about experience sampling is that we have several moments in a row. We ask people to fill out this questionnaire several times a day, so you can actually see how long does it take someone to go back to their sort of average or basic level of, for example, negative affect. And so again, here we looked at healthy volunteers, people with the first episode or in the early stages of psychosis, and people who were more in a chronic state of psychotic disorder. And so what you see here, this is the healthy volunteers. So this is the moment when they actually have stress. When they report the first stressor of the day, you see a slight increase in negative affect, so it affects people's mood. And then the moment afterwards, it already immediately goes back to its average state. So people are not so much affected. You have a slight peak and then it goes down. When we look at the people with chronic psychotic disorder, you see that their average negative affect is higher. They score on average higher. They have a peak, but they also go quite quickly back. When we look at the early stages of psychosis, however, you see that there's a larger peak, but it also takes much longer to go back to their average state. So it takes them 3 beeps to go back to their average states, suggesting to us that the stage of recovery takes much longer. So you can imagine if you constantly are overly sensitive to small stressors that happen to you, for example, in a big city, and you're constantly overreacting and it takes you longer to go back, then it has quite a significant impact. And the same was true for suspiciousness, so it again had an effect on the psychosis, and then it took them 2 beeps to go back. Now, that is really an advantage of using experience sampling, that you can look at these temporal associations. We can also use this to see how people are interacting with their social world. And interestingly, we can look at sort of what we call objective ESM measures, so you can just see how often are people with other people, how much time are they on their own. But you can also look at social experiences, so how do they feel in these social interactions. When we look at how this social context, then we see, and this is a large data set that we collected together with a lot of collaborators when I was still in Maastricht. This is a data set from Maastricht, where we collected a large number of healthy volunteers, people with a risk for psychosis, both genetic and psychometric risk, people with a psychotic disorder and with depression. And so what you see is that people with psychosis spend more than 40% of their time on their own. Much more than healthy controls. This is also true for the 2 other groups, depression and psychosis risk, but it's most pronounced for people with psychosis. And they spend then obviously less time with people, with family and friends, and people they don't know that well. What is interesting is also when you look at this data, that you can start to understand a little bit more on what it means to be in remission and whether we should be satisfied when people reach a state of remission based on their symptoms. So what we did was we looked at a group of people who were not remitted, 70 patients who were remitted and controls, healthy volunteers. And the people that were remitted based on the PANSS, so the PANSS criteria, so it's really based on symptoms. And then this was quite interesting. So what you see is that both groups, remitted and non-remitted, were still equally spending much more time on their own. Spent much more time doing nothing, and spent much less time in what we call goal-directed activities related to work, studying, etc. So this is quite humbling to see that when we say someone is remitted, that only a very small proportion of the problem is tackled, which is there are less symptoms present. But it is not necessarily helping in terms of recovery or in terms of helping to start to reconstruct your life and get your life back on the rail. An interesting study in that respect is also one that was done by Susanna Casanova in my group, to look at what we then call asociality, one of the negative symptoms of psychotic disorder. And what we actually argued was that we are talking about people, but we're sort of comparing apples with oranges in the sense that when you look at the actual living conditions of people, they're quite different. So when we look at healthy volunteers, we see that most people have vocational activities and are living together with other people. Individuals with psychotic disorder, the largest group has no vocational activities. Some people live together with others, but a lot of people also live on their own. And so we actually were thinking, so what we say, or the conclusion that we take, is that really based on what people want and the actions that they take, or is that really due to the circumstances and the living conditions that you're in, which are quite different, clearly. So what we did was we looked at the amount of time that people spend in structured social contexts. A structured social context is a context related to the fact that you're in a social context due to the fact that you live with others or due to the fact that you have a job. For example, the reason that we are sitting here all together is not so much because we're also social people, we're here because this is part of our job. We're here, we meet other people as a part, so a lot of times you're in contact with other people, you don't have to do anything for it, you don't have to take action for that, it's just part of the fact that you live with other people or that in your job you meet other people. So what we found was, if we look at the effect of that social context on positive affect, we see that both healthy volunteers and people with psychotic disorder have more positive affect when they are with others in this structured social context. However, people with psychosis spend much less time in this structured social context. Now let's look at unstructured social context. This is a social context where you actually have a freedom to choose, or where you have, it's going out with friends, it's things that you do in your leisure time, which are not related to these two factors that I mentioned before. When we look there, we see that there's more positive affect of both groups, but also that there's no difference in time spent in this unstructured social context. So when we talk about asociality, we're actually describing the circumstances. We're not describing a quality or a characteristic of a person. And it's actually much harder to get in this unstructured social context. This is something where you have to do something. And so basically, I think this is really showing that the social environment is influencing or has a crucial impact. It's a context that has a crucial impact on how, for example, these social experiences. Okay, so as I showed, with experience sampling, we can understand symptoms better, and we can start to understand a little bit better how the context and the environment is impacting on the experiences of individuals. The next question is then, if there is variation in real life, and if that is where things are happening, is that also a place where we can intervene? Can we do something in the real life? And can we use this methodology to do that? So we are working quite a lot now on what we call ecological momentary interventions. And basically an ecological momentary intervention is an intervention where you try to take the therapy out of the office and into the real life. So you deliver therapy in the real world at moments when it's most needed. And in a way, it's a sort of round-the-clock support. And it may induce sustainable change. I will explain that a bit more. So what we've done is we are currently doing the INTERACT study. It's a multi-site study with lots of places in the Netherlands that are people in Amsterdam, Eindhoven, and in Flanders, Leuven, Brugge, Melle, different places. So it's a large study where we're actually investigating, so here you see all the participants, where we actually try to see whether we can bring the therapy out of the office and into the real world. So what we are doing is we're looking at acceptance and commitment therapy, and we call it now acceptance and commitment therapy in daily life. And we use an app to actually deliver part of the treatment in the real life. It's a clinical trial. We compare it to treatment as usual and CBT. So what do we do? In this study, we basically deliver treatment by a therapist. So people see their therapist in 7 sessions, each time committed to one specific aspect of acceptance and commitment therapy. And then, that is the crucial part, next to that, people get their smartphone. So after each session, they get the next 3 days after a session, they start working on their smartphone with what they've learned in real life. So how this works is that people, again, get beeps in their normal daily life. They fill out a shorter questionnaire about the current state, so it's sort of helping to be in the here and now, a sort of mindfulness experience to each time think about how do I feel right now. And then we give them either a short exercise or we give them the metaphor that was used in the therapy. And so the reasoning is that if you try, because one of the problems of psychotherapy that it's so hard to bridge the gap to the real world. You work on things together with your therapist, but then applying these at moments when it's most needed is often hard. So what we're trying to do is, the argument is that if people practice in their normal daily life with all sort of experiences that they have, that they will also be able to use it at moments when it's most needed, when you're really anxious or have lots of voices or things like that. And so this is how it works. Each week it continues, so 3 days a week for each week. At the final sessions, it's about values and commitment, committed action, or value-based action. And then we really try to help people to each time think about, so they define what they want to work on, and then we remind them a few times over the day, are you still working on this? For example, I want more contact with my family. What can you do, and how can you? And then we help. It's sort of structuring that. And then, of course, they have access to all the exercises constantly, so they can also go back and practice more if they like. So, in total, well, the study is now finished, so we now have slightly higher numbers than is said here. So we ended at 148 participants. Unfortunately, I can't show you the data yet because there's still people doing the final sessions and the follow-up, so we soon will be analyzing this. We asked to a smaller group how they felt about it, so people thought the training was useful, the ACT sessions were useful, and the home exercises were useful. They found the app on a scale from 1 to 7 relatively useful, and they said that it really helped them to become aware of the experiences on how they feel, but they also found it quite burdensome. The number of beeps per day and the duration of the beeps was burdensome. So we also did a qualitative study. We asked people about how they experienced this, and these are just, it's not a formal analysis yet, that's also still on the way, but this is some of the things that we got back. So for example, people would say, this is the first thing that really helped me. I very strongly believed my thoughts, that has calmed down. The app is helpful because it brings you constantly back. Remember your exercises, your breathing, what do I feel? The app created awareness about what I was doing and what I felt. But they also said, I did not like the beep so often, that irritated me. The questionnaire was very long, that was annoying. The same questions came back over and over again. So we currently were lucky to have, this is part of an ERC grant, and we now have an ERC proof of concept grant where we can actually take this into account and develop the app further based on all the feedback that we get from the qualitative study, from the therapists that were involved in the study, to improve the app so that it's really becoming a useful clinical tool. So that sort of, I have no idea of the time, so I think I'm probably already over. So I will conclude. So I think with the experience sampling method, first of all, it brings the person back in the picture, and of course, the person's, I should say, the personal experience, what people's experience in their normal daily life. It captures the interactive phenotype, it captures how people deal with their environment, how the environment impacts on what people feel. And most importantly, I think it provides a tool for people to help themselves in real life. And this is what we're working now on. We're currently working on an implementation study, not just for the ACT in daily life, but also for experience sampling itself, to really use as a clinical tool. I think one of the really nice things about experience sampling is that it's empowering, that you give a person a tool to bring their own experience to the table. So I think it's really a tool that would improve shared decision making, and that would also help people in self-management. So I think this is really a way forward to what I call a science of behavior, understanding how people feel and behave in the context of their normal daily life, but more importantly also in precision medicine in psychiatry, because every individual is different, the risk patterns, the patterns of behavior are very different, and with this tool, everyone has a tool to actually look at his or her own data. And so that is really where I want to conclude. This is my team. If you want to reach high, you have to jump high. And it took us at least 5 times to get up in the air altogether. And these are the people that I'm working with and the funding agencies. Thank you very much for your attention.